Hello, good morning, everyone. So I would like to welcome all of you to this topic on focus session. And today we are going to open the first of 11 webinars once per month, targeting people living with sickle cell disease, so patients and families. So today we are going to talk about new therapies for sickle cell disease. Here with us, there is the Dr. Malika Benkerrou, who is pediatrician at the hospital Robert Debré in Paris. And she's, of course, an expert of sickle cell disease. She coordinates many actions and many projects in the department of Hospital Nord in Paris, and also in the Label Reference Center for Constitutional Red Blood Cell and Erythropoiesis Center. So, Dr. Benkerrou, I will kindly ask to share
the screen
presentation so we can see it works. And of course, then the floor is to you.
So
Great.
I would like to thank everybody. First, to wish you a happy new year, despite all the problems we are facing, actually. And I don't know if there is native speaking, native English speakers among us, because I'm not. And my English is poor, but my tailor is rich. So I apologize for the way I will mistreat English. We will first have an introduction on sickle cell disease, then on modifying therapies, on curative approaches. We will talk about comprehensive sickle cell disease centers and what I mean with it. I will share with you some take-home messages that we can modify together, and then we will discuss. So first, as you know, sickle cell disease is the most frequent monogenic disease together with beta thalassemia. It's a point mutation on the 6 codon of the beta globin gene that modifies the protein, the beta globin protein, that instead of A becomes S. The S hemoglobin is doing its work fine, meaning it's taking the oxygen that we are breathing and it releases it to the tissue very well. The problem is that hemoglobin S polymerizes upon desoxygenation. That means that it makes fibers inside of the red blood cell, modifying the shape of the cell, rigidifying it, and fragilizing it. It has 3 hallmarks. The one is breaking down red blood cell chronically with chronic hemolytic anemia. The second one is vaso-occlusion of the small vessel responsible for pain crisis, as well as stenosis of very large cerebral arteries with increased risk of stroke. There is also the third hallmark, which is a high susceptibility to encapsulate bacterial infection due to functional asplenia. Diagnosis is very easy for adults with an exam called hemoglobin electrophoresis together with blood count. It's more complicated for newborns, which are mainly newborns, and have mainly hemoglobin F instead of hemoglobin S, which is the adult hemoglobin they will have. The other thing about sickle cell disease, it is wide biological and clinical variability. It's true from patient to patient, but it's also true over time at different times of life. I only take an example that most of you must know. It's a very old paper with more than 2,000 patients with homozygous sickle cell disease, included in the late 70s and late 80s. At the time, there was no neonatal screening nor implemented care after neonatal screening. It was in the US, and they saw that 40% almost of the patients had no pain episode per year, that 1% of the patients had more than 6 episodes per year, and then 5% of the patients had 3 to 10 episodes of pain per year, and they were responsible for the third of the recorded pain events. We have, for the moment, epidemiologic risk factors, but no individual prognostic factors in order to know what kind of sickle cell disease, except the genotype, because you know there is different association between S and other abnormal hemoglobins. And for instance, homozygous sickle cell disease has not the same severity. It's more severe than compound heterozygotes SC, for example. So one way to see why we cannot find prognostic factors is that it's a nematological disease, but also a rheologic disease, meaning circulation is not easy into the vessels, and there is oxidative stress ongoing, inflammatory stress ongoing, hypoxia, reperfusion stress, and all the cells into the microcirculation and all the tissue polymorphisms will play a role in the way the disease is going to be expressed. The other thing we know about sickle cell disease, it's very early mortality and morbidity, which leads to, without care or in low income countries, to 50 to 80% deaths before 5 years, mainly infectious and anemic. But what is also very, very important is you can prevent both death and both mortality and morbidity with simple measures that are getting more and more complicated through neonatal screening, organized health and social network. And the mortality before 5 years of age in the latest publications are less than 1%. So we will, I think all of you know what is prevention, antibioprophylaxis, anti-pneumococcal and meningococcal vaccines, parental and referent adult education to symptoms, use of treatment, preventing pain, acid folic supplementation, support to treatment compliance, regular outpatient and annual review, and regular TCD measuring the velocities into the large cerebral arteries to intervene early. Early intervention consists with transfusion programs, hydroxycarbamide or hydroxyurea, which is the same thing, hematopoietic stem cell transplantation, and other disease-modifying or curative therapies that we will speak of. So now, what about the targets? We saw that the whole vessel, the cells inside are activated, and what we can do is try to change erythropoiesis, which is the way to change erythropoiesis, not make any more hemoglobin S. Try to prevent adhesion of those activated cells to the endothelium. Do you see my my mouse when I show? Yeah, thank you. We will look at anticycling agents to prevent the red blood cells take those abnormal shapes. We can also preserve the vasodilatation of the vessel to prevent vasoocclusion, prevent the results of hemolysis, which is free and oxidant reactive species. That's one point. The other one is that we know for more than 30 years that without any care in the US, has been published a study about probability of survival on 2,500 patients. There was no neonatal screening nor implemented care. And what we do see here is that the life expectancy of those people were low, 42 years for men, 48 for women, meaning that 50% of them were dead at that time. But what we see also is when fetal hemoglobin was higher than 8.6, then without any care, life expectancy was more than 60 years old. So that means that fetal hemoglobin plays a crucial role despite all of no other care on sickle cell disease phenotype. So disease modifying therapies, we will speak of anti-cycling agents, anti-adhesion therapies, optimizing oxygenation, increasing fetal hemoglobin expression, substitutive therapies, empowerment, and prevention. The first, I will speak of some of the anti-cycling agents. I will speak of GBT 440 called voxelotor that is maintaining the hemoglobin in oxygenating form by binding covalently to alpha genes. So it lowers polymerization and cycling. Therefore, it increases hemoglobin, decreases hemolysis parameters. There are trials that have been done in adults showing those elements and safety. And there is an ongoing trial for kids with conditional TCD versus placebo. As you know, the velocities are increased by increased anemia. So that's a trial we are going, which is interesting. Other anti-cycling agent, the pyruvate kinase activator, FT4202, his name is etavopivat. It increases hemoglobin affinity and increases red blood cell repair. Why? Because it decreases 2,3-DPG and increases energy inside the cell, the red blood cell. Decreasing 2,3-DPG, it increases hemoglobin affinity for oxygen. Then there is less desoxyhemoglobin S. And the sickle cell disease trial showed that it increases hemoglobin, therefore decreasing anemia, and it decreases drastically hemolysis. There is a FASH-2-3. It has a very good safety trial. It's taken like voxelotor once a day. And there is a clinical trial ongoing for kids with 2 or more vaso-occlusive crisis, drug versus placebo. Anti-adhesion therapy. We will consider anti-P-selectin. The selectins are molecules on the cell that are expressed. P-selectin is on platelets and on endothelial cells. It's expressed upon activation. It's a way for the cells to roll on the wall of the vessel. And this rolling is just before the cell will stop on the endothelium. So, and it applies also for the polymorphonuclear cells that are big cells and very adhesive ones. And it has been published that it reduces, cresenluzumab reduces by 30% the vaso-occlusive rate. It's taken not orally, but intravenously 2 times a month at the beginning, then once a month. So it doesn't need every day taking a drug, but okay. In our team and adult centers, because the trials have been done on 16 to for adults, and we are a pediatric hospital, so we have few patients between 16 and 18, but we have, in our experience in adult centers experience, it's interesting in patients that do take their hydroxyurea or hydroxycarbamide and remain symptomatic, but those who need hydroxyurea remain very symptomatic. So it's not, it shows that combination is the way we will evolve. We will treat our patients. Another point is, could we optimize oxygenation and could be a preventive strategy? That's what we saw in a newborn cohort study for over than 7 years, using longitudinal biological and clinical data, and modelized adapting statistical methods to the fact that, for example, fetal hemoglobin is modifying pretty quickly in the first 5 years. Reticulocytes are gaining, are increasing in the same period. And we looked for macrovascular cerebral disease. The identified risk factors by ×2 per year of ENT obstruction or bronchial obstruction or reticulocyte count increase, were all risk factors for macrovascular cerebral disease. The only protective factor in our cohort was the way the increase of fetal hemoglobin and the way of it declines over time. And those are easy factors to target. ENT is easy to diagnose, and you can do amygdalectomy or adenoidectomy. Bronchial obstruction, we have inhaled therapies. Reticulocyte counts are modified by hydroxycarbamide as well as fetal hemoglobin. The other thing, and she, our colleague showed that the way you look at the biological parameters, for example, modified your results. So it's why the same complication will have very different risk factors. That means that most of the study take it into account data at 2 years of age and analyze every event with it, or data at the end, last data available, or the mean of the data. And that does not respond to the variability of biological events and their the time they occur. So that's a very interesting study. Now, could we re-express fetal hemoglobin that is been shut down after birth? One technique is gene therapy. It targets the gene that silences the gamma globin genes that are characteristic of the fetal hemoglobin. Therefore, silencing this silencer permits fetal hemoglobin expression, and it has been done recently in 2 patients, one with beta-0 beta plus thalassemia, transfusion dependent, and one with sickle cell disease with frequent vaso-occlusive crisis. It needed myeloablative conditioning regimen. And if we speak of the sickle cell disease patient, he has only F cells, meaning red cells containing almost 100% of fetal hemoglobin. And his fetal hemoglobin rose from 9.1, and she is an adult more than 30 years old, to 43.2%, and his hemoglobin S decreased at the same time from 74% to 52%, and she is free of symptoms. It mimics a benign condition, which is on one what we call allele, on one gene. You do not make adult hemoglobin, but only fetal hemoglobin. And on the other one, you make adult hemoglobin, either A, which is normal, or S, which is abnormal. And the condition, hereditary persistence of fetal hemoglobin, this condition with hemoglobin S is benign. So this gene therapy showed what was seen previously in mice and realized, but we need more time and outcomes to know what happens really. And it's very heavy therapy and very it costs a lot of money. Okay. So here we are going to speak about a drug that was supposed to increase fetal hemoglobin. What it does, hydroxycarbamide, which is a ribonucleotide reductase inhibitor, which ralentir, which
slows.
Sorry?
Slows, degrades.
Oh, yay. Thank you very much. Which slows the DNA synthesis and orients the hematopoiesis toward the fetal hematopoiesis. But it has a lot of other effects that we talked before. Enhanced hemoglobin F, yes. also it decreases the number of other circulating cells like white blood cells, platelets, and reticulocytes. And those cells are no more adherent to the endothelial wall and between each other. It decreases the most potent vasoconstrictive phenomenon molecule, which is called endothelin 1. Therefore, it decreases also endothelial injuries. It ameliorates deformability of the red blood cell, and it enhances the molecule that permit vasodilation, which is nitric oxide. So here, to say it short, here's a blood smear from a patient taking hydroxycarbamide, hydroxyurea. And after 6 months, you see that there are less misshaped red cells, and they are mostly round. The problem is that it's terribly underutilized. In a study we have done in France over more than 1,000 of newborns, 40% or less of them with frequent VOCs or severe anemia were treated with hydroxycarbamide. So several problems. The first one is that few people know that it has reversible effects and no mutagenous effect, meaning that, which is no good, that when you stop it, there is no more drug and there is no more effect on the body and on the red blood cells. So you are becoming sick. And you are going to have a talk, I saw it, in some months about hydroxycarbamide. There is no malignancies because it doesn't break DNA. So a lot of people, because it was used previously for very old people leukemias, myelogenous malignancies that are predisposed to acutization. So there has been a big mixing in the head of the doctors and in the head of the patients on malignancies and hydroxycarbamide, which is too bad because it's the most effective drug we have got. So, old dog, new tricks. You can now, we have found methods to make exchange transfusion, which is just a substitutive therapy. You give normal blood cell and you take out misshaped red blood cell with sickle cell disease. The problem with almost all transfusion programs is that you create iron overload. So there is apheresis machines that can do the job, but you can do continuous manual exchange transfusion with the same results, and that's done by colleagues that came and learned it in middle income countries, because in low income countries, there is not enough blood. So preventing iron overload is very, very important. Then, how could we have create a monthly national neuroradiology expertise meeting, because most of exchange therapies are done for cerebral vasculopathy. So by reviewing images and charts, we prevent erroneous transfusion therapy because programs, because it was just artifacts, and we could, if the images normalize, the velocity normalize, safely resume transfusion programs. So that's what multi-professional team and sharing knowledge and patience permits. That's Geo, which is looking at you. So all those things are nothing if there is no support to the parents and to the kids, and empowerment both to parents, kids, and adults. We can speak of psychological support, restore self-esteem, try to address stress control, because it's a very potent element for the appearance of vaso-occlusive crisis. Mediation, because in Europe, most of the patients are from other cultural backgrounds, different from the healthcare givers, except that in our team, we are from very multicultural background, but it's particular. So we have to use mediation to understand each other, respect different cultural backgrounds, and communicate. We have the treatment adherence, which is sharing knowledge between educated healthcare provider, parent, patient experts, adults, and children. Because oral medication we spoke about work only if they are taken, and taken without a burden, without energy that you put it. So for that, you have to do it for personal goals that are different from patient to patient, from age to age. It has to be encouraged, supported. To be discouraged is normal, so it has to be shared. And for the healthcare providers, they have to know that the base dosage has to be reached very quickly, because otherwise it discourages parents and patients. We can use also modern tools that are used by adolescents and young adults for support and empowerment. And we made an application with on a smartphone connected to a dedicated nurse platform where we enroll more than 150 patients in Paris area with magnificent results in all fields. And it's very supported during transitioning from pediatric care to adult care. I think prevention is the best tool, and we have to empower existing preventive strategy as well as implement new ones. What we have seen looking at more than 1,000 of newborns with sickle cell disease in North Paris is that there is gaps such as no treatment with hydroxycarbamide for X reason. There is loss to follow up because of moving. So we have to have a very good networking. And we show that there is a high level of social difficulties in this area. We are in the north of Paris, and most of our patients have newly emigrated to France and to Paris, so they are integrating in French society. So that's why we and the colleagues of the region started a monthly meeting on pediatric complex situation, which is a mixing of social, psychological, cultural, and disease problems. That makes an interesting soup. Curative therapies, first bone marrow transplant or hematopoietic stem cell transplantation, and we'll speak also of gene therapy. So the most well-known and the most widely done is allogeneic bone marrow transplant with an HLA identical sibling, meaning with identical tissue identity shared between the donor and the recipient. As you know, it needs to erase the bone marrow of the recipient with high myeloablative conditioning regimen. It has some very good things because I would say 80% of the patients are so-called with a new bone marrow, which is the marrow of the donor, and add no more sickle hemoglobin. But you have to have a matched donor, and only 1/4 of the patients have such a donor. There is mortality, 5%, which is around the bone marrow transplant process. Chronic disease called chronic GVHD, which is recognition of the recipient body as foreign by the white blood cells of the donor, which is 12%, and it has a toxicity on organs that we don't need. First, it induces sterility, so you have to preserve sperm or testicles for the small ones, or parts of ovarian for fertility. It's toxic at the time you infuse it, and it is mutageneous, which is different from the drugs we saw before. So immediate toxicity and long-term toxicity, but the 80% and more are cured with no chronic disease, which is very interesting. And together with the bone marrow transplant unit, we coordinate an international multi-professional consulting meeting for discussing patient to whom we can propose bone marrow transplant and which type. So, allogeneic bone marrow transplant with heavy conditioning, we saw that it has a toxicity. To reduce toxicity, you have to reduce conditioning, which has been done and published. That's what is called non-myeloablative conditioning regimen, with the use of antibodies, total body irradiation, cyclophosphamide, and then immunosuppressive drug at least for 1 year. This process has, you have to have an HLA identical sibling, same problem than before. There is a higher rate of rejection, which we don't have in with myeloablative conditioning regimen, with 10% more or less rejection in the first year. There is always only what we call a partial chimerism with a mix of donor and recipient cells. It has been done in a small amount of patients, adult ones. Small amount, meaning that we don't have thousands of patients, but all together with different strategies, less than 100. And the problem with partial chimerism is the long-term outcomes, meaning the risk of rejection over time. The lower is the chimerism, the higher is the risk of rejection over time. I will not speak about haploidentical bone marrow transplant with myeloablative conditioning regimen because of it has been published. It had initially a high rejection rate, but with chemotherapy after transplant, that rate of rejection lowered, but data are not consistent, and so I won't show you. We have there has been toxicities of different types, but it exists. It will progress, but because haploidentical donor is available for everybody almost. What about gene therapy in modifying erythropoiesis? it has been done in several teams. Here is the report of the Necker Center with Marina Cavazzana Calvo. I put only the sickle cell disease with patients with large follow-up with because it's 4.5 years. It enroll only patients with frequent vaso-occlusive crisis, no vasculopathy, and it's an autologous transplant with modifying the with transfection of modified hemoglobin gene through a lentiviral vector. Because there is no advantage of the new marrow that you reinfuse to the patient. If you don't understand, you stop me. That means you take the marrow or the circulating stem cells, peripheral stem cell, you harvest them, you take them to the lab, you cultivate them with the virus with inside the modified hemoglobin A anticycling hemoglobin. Then it goes into it's targeted and it goes into the DNA, insert itself and express itself. And then it's checked and re-injected to the patient after a myeloablative conditioning regimen, okay? 2 out of the 3 sickle cell disease patients treated in Paris were cured. The third presented VOC and had to go back to transfusional therapy. So now, why do I think, and what do you think, we need comprehensive sickle cell disease centers? Because that means that it's a holistic approach of the patient, multi-professional, and it's a network. And we need to do that in every country. If you disagree, I can discuss with you. So everything has to be centered around the patient or baby here, because I'm pediatrician, adult. So we have here a lab reference center, multi-professional team with mediators, hospital-based. It will coordinate first a network with a proximity hospital with specialized pediatrician that has been labelized, and there will be exchanges between competence and reference centers, meetings, discussions, and so on. Refer when a patient needs specific therapies that are not available in the proximity hospital. Then you need to collaborate with the family doctor, the other healthcare providers around the family, and to communicate with them. We have what we call regional handicap houses, which is a bad translation, but meaning it can provide help for parents that had to stop partly working because of the disease at a time for the kid, or specific needs for the kid. We have to communicate with the school doctors in another way with the teachers. We have a teacher in our center and communicate in the with the educative and psychosocial system around the school. And we have maternal and health care system for mother and kids in France. I don't know if it's available everywhere. And all those people, because the kid is not to be maintained at home. It has to go everywhere that are where other kids are going, and it has to be safe, and everybody has to be comfort. The parents should be comfortable in leaving their kid to go to school or to go in go camping or whatever. So what I try to share with you is that the time from research to care going fast is tool for better life. And now things are going faster from bench to care in the 5 last years. We need better disease control, optimize what we have for prevention, and we have to know that if the disease is there, we know as a newborn, we don't need the disease to show it's here. I mean, pain is burning kids' parents forever. So don't wait for sickle cell disease to show it's bad. It's bad, prevent it. We have molecules, we have drugs, we can do things. So we can prevent with known or innovative drugs. We can cure with known practices or new practices. We are starting to find a lot of new modifying drugs. It's ongoing. Patients and kids have to have access to international trials if they want to participate. And we have to have the good tools for statistical analysis. Otherwise, we don't trigger the right risks. We have to evaluate in real time what we are doing. And everything is done to live well without being burdened by sickle cell disease. Therapeutic education together with drugs, new therapy, progressive empowerment toward adulthood, and to have a life project. What happened? So the diagnosis announcement is for building a therapeutic alliance for life and for as good life as possible. Some take-home messages that I want to share with you, and I would like to change them with you, if you'd like. Collaboration with healthcare providers, parents, children, patients, advocacy for networking and for referral centers. Just to say that there was a huge progress in the past 5 years in the available drugs and trials. And it's time for prevention and tailored therapy with combination of approaches following the need of the patient for the quality of his life. So that's our team. They didn't want to show the pictures. So I would like to thank you very much. Here is our hospital, Robert Debré, and we are doing all we can for her, and she thank you.
Thank you very much, Dr. Benkerrou, for your comprehensive speech. Sorry, I interrupt you. You would like to add something?
No.
No? Okay.
No,
Sorry,
I spoke. It's your time.
Well,
So,
not yet, because we have one question in the chat, and I encourage also the audience if they want to address some of the questions. We don't have that many time because we run a little bit, but we can try. So the first one, in the future, would non-myeloablative regimen be considered for gene therapy, as it has been associated with heavy side effect on sickle cell disease treated patients?
the problem with non-myeloablative therapy is that there is a high rate of rejection, and there is no, it could theoretically, but you need to make space for the modified cells. Immunomodulation for the moment has not been considered. Did I answer?
We can ask to Yolande to confirm us in the chat. Yes, she said, thank you, Malika. And also, I would echo many feedbacks received in the chat saying very excellent presentation, thank you. So one questions. Thanks for the presentation. My questions are, in patients that are treated with gene therapy, does they need some immunosuppressors treatment for life? What do you think about the expectation of gene therapy?
I would say that we have few patients, many trials ongoing for sickle cell disease. It's a tricky therapy, but we are making huge progresses because many efforts have been done on it. So we have to be very cautious because to put a gene inside DNA, the gene has to be insulated so it won't insert anywhere and make appearance of leukemia or other problems. So for the moment, it's very tricky. We have had some bad experiences around the world. I think we are doing progress, and the Cas-CRIS therapy that I showed you is much simpler than introducing a viral vector inside. I didn't show you that some molecules that are able to silence BCL1 11A were on trial, but not very, did not show efficacy, but we are progressing hugely. And gene therapy is not, we have to be cautious, but we have patients thriving after gene therapy. So there are few of them, but before 10 years, we had none. So we are progressing. Exchange transfusion, how do we deal with vascular access? We put implantable chambers for the kids when we don't have vascular access. And we have so far no problems with it. We have a huge exchange therapy unit. We do more than 1,000 of apheresis per year, mainly for cerebrovascular disease, because the patients are referred to us because it's complicated. You have to have the machine, or you have to have the time with 2 nurses to do continuous manual exchange. But we deal it, and you have to deal it quickly, because when there is no more veins, then you are in trouble, and mainly the kid is in trouble. After that, yeah, you can do fistulas for better exchange therapy. Other questions?
Not at the moment. Yes, one. What about the need of immunosuppressor? Are they needed for life?
No. After gene therapy, you have no immunosuppression. You have short-time immunosuppression post bone marrow transplant, 1 year, longer and heavier when it's reduced intensity conditioning regimen, because it's mixed chimera. No, it's not like organ, it's autologous. Gene therapy is autologous. And bone marrow transplant with HLA identical donor, the HLA are matched, and the minor mismatches are very much erased, and the donor white cells get used to the new body. So you can stop immunosuppression usually after 1 year if there was no problem. For reduced conditioning therapy, you have to modulate to maintain the remaining immune system of the recipient low, so that they won't reject their graft. And gene therapy is done by autologous marrow or stem cells or whatever. So same person.
Thank you. I will read the very last comment because we are really out of time. So one last comment will be how to convince specialists to explore new therapies and solutions. We see a lot of patients keeping on having vaso-occlusive crisis without having proposal to reduce the crisis and complication frequencies.
I will say that the earlier you start, the higher the right level of therapy you start, the easier the disease is going to be controlled. And we know, for instance, that using hydroxycarbamide very early in life will prevent a lot of pain problems in the kid and in his surrounders, in his family. And you have seen, or we had no time to see it, that there is a wide intricacy, complex intricacy between the way we feel and the way we are sick. And also, the more VOCs you have, the more your body will react to it, and you get neurologic feedback, which is called neuropathic pain, and you get into chronic pain. So the main word is to prevent and understand each other hand to hand to prevent the disease to express. That's what, and there, with that approach, because the main hydroxycarbamide inefficacy is when it's not taken at the level you need it, or it's taken sometimes and not sometimes. So you don't have to let it's like having a tiger in your house. You don't have to open the cage. You have to keep it closed. Am I clear?
Yes, I will say yes. And also Yolanda say oui. So we all agree you're clear.
I think that having led the tiger into your body and your house, then you have problems that are going to be huge to face, and you are going to be frightened for life.
Yes. So thank you very much, Dr. Benkerrou, for your speech. I've seen last comment on mental health and psychological need. Yes, we just had one session on that recently with people with sickle cell disease at ASCAT. So indeed, it's a very important topic. And it's also related to next session of this webinar program that will be held on St. Valentine's Day, on the 14th of February. We could be together, and we will talk about adult patients' quality of life with Dr. Noémi Roy. So I hope to see all of you in less than 1 month, in 2 weeks. And I wish to all of you a nice evening. And again, thanks for the great debate, the presentation, your time and expertise, sharing the expertise with us, Dr. Benkerrou.
Thank you very much. And I would say that what I described is a holistic approach And there is not the doctor and the patient. There is life, a disease, which is part of the patient, but not the patient. And we have to take the patient and his family as it is. The environment, everything. The fact that people are not working in referral centers, in networks, make that they are not able to have that holistic approach. That's why it's mandatory.
Yeah, that's a very good
Thank you.
take-home message. Yes, that's a very good one. So we will keep your words with us, and we will try our best to improving what we could improve for this disease in many different aspects of the healthcare, as you said. We will try. So thanks for your inspiring words also.
Thank you.
And see you soon. Thank you very
Together
much.
we
to
can do a lot. Alone we are nothing.
Yes, it's always like this. Yes, indeed. Thank you. Have a
Bye-bye.
great
Good
evening.
evening.
Bye-bye.
Bye-bye. See you.